This is Retinawesome Mentor, another interesting case in vitro retinal surgery. I'm Dr. Hudson Nakamura, retina specialist.
This is an inverted vitrectomy surgery.
So the case is evolving surgical strategy in retinal detachment, pneumatic retinopexy transitioning to vitrectomy. So you see the case here is the inverted image of the right eye of the patient with MAC off, retinal detachment, the macula is off. As you see here, subretinal fluid, and a large supratemporal break. So the first approach was to do pneumatic retinopexy because the left eye was not eligible for anything. It had the long-standing retinal detachment, as you see here. So we started the pneumatic retinopexy, as you see here. The patient is phakic. So SF6 was in. And actually, the retina was attached for a while, for a couple of weeks. As you see in the post-operative period, macula is on, the retina is flat, gas is all right. But after a while, the retina got detached. So it was the patient's only eyes. We had to proceed for a vitrectomy. So a 23 gauge parasplana vitrectomy started. As you see here, there is some vitreous detachment as well, vitreous opacities. And with a wide angle vitrectomy viewing system, the vitrectomy was started and the vitreous was removed. You see there the large supratemporal break, quite large one. We had to avoid the mobile retina and also the lens as well. So we had to be there in between the lens and the retina and trying to avoid it maximum in order not to get a cataract. You see around the break, you see some of the vitreous attachments over there. And still with the same lens, we get the overall view of everything. And the first approach, this is a very interesting image, and you are up to the retina periphery. And the break has to be enlarged somehow because there is a retinal shortening there. As you see here, I'm removing the attached vitreous at the very periphery. We have to follow the instruments with the eye at the same time, of course, in order to avoid hitting the lens. And I'm performing this radial retinotomy from inside out. So I'm going towards the retinal periphery. And of course, you see some subretinal blood coming in. It's difficult to avoid all peripheral vessels. And the thing is here is to make the retina very mobile in order not to let it open and without, the thing is to relieve the tractions. And now I'm aspirating very carefully the subretinal blood with the back flush cannula. You gotta use it to lift it up, to lift the retina up, and then you go straight down inside the subretinal space there. You see some bleeding that you can control, of course, with the raising of the intraocular pressure, avoiding the lens always. The lens is clear. And now after doing that, injecting peripheral carbon liquid that is gonna actually attach the macula. You see some remaining of the blood, the subretinal space there, but it's just a few. It's gonna resorb with time. The lens is very clear, as you saw by transillumination. And now the next step of the procedure is to do endolaser, not much endolaser, but enough to keep the retina attached there. This is the first row. You see that the retina is very flat. The detachment and the break was relieved. So we contour here around the break. See, lens is clear and the retina is beautifully attached. The macula looks like never had been detached again. Of course, I'm completing the laser around the retina periphery superior now. And you see here inferiorly, the work has to be done as well. So the 360-degree endolaser therapy is completed now. And the retina looks beautiful again. And the thing is, now I'm preparing for the direct exchange of fluorocarbon liquid for silicone oil, and you see the retina keeps flat. There is air in between the lens and the cornea, and that is great because that makes my image visualization very cool, very good. And these small droplets have to be removed. Of course, waste a little more time with that. The pupil is already getting, smaller, but the retina got it attached. And you see here the OCT showing after a while. So the emulsification of the silicone oil that happens, and I'm removing in another procedure here. The lens is still clear, so I decided not to do cataract surgery at this time. You remember, the patient is on the eye. We have to be very careful. This is a simple technique of removing the silicone oil. And as you see here, an fluid exchange is performed. The retina is fully attached. You see the old break there is very well treated, and the laser scars and everything seems to be very, very flat. So a very good case, and the lens still clear, as you see. Some peripheral lens opacities, but this is the detail that I just showed you. We gotta remove all silicone oil and PFC bubbles. The patient got 20/40. This is amazing. A very good view in the post-operative period. I really appreciate your attention. Thank you very much.